I start with the. So, a very good evening, good morning, or good afternoon, depending on which part of the world you are all joining us. And a very warm welcome to this 13th academic webinar of TUGSS Endoscopy. I'm Dr. Bhavneet Bhalla. I'm the global coordinator for TUGSS Endoscopy, and today I, along with my TUGSS executive member, Dr. Parth, are going to moderate this session for all of you. So today we are going to talk exclusively about endoscopic intragastric balloon placements, and we will delve into this innovative non-surgical weight loss intervention technique and explore the efficacy, the patient selection criteria, the procedural nuances, and the evolving scope of this procedure in managing obesity. So we have an esteemed panel of experts who will share their insights, experiences, and the latest developments in this transformative field. As always, I would request all of you to please post your queries and comments in the chat box, and we'll put them forth to the experts on your behalf. We'll be having a panel discussion and a Q&A session after the guest lectures. So to set the ball rolling, I would request Dr. Path to please introduce the chairs for the session. Dr. Path.
Thank you. I am honored to introduce to you two of our expert panelists. I would first like to introduce to you Dr. Siddesh G. He is an endoscopist, laparoscopic surgeon, medical director at Sigma Hospital, Mysore. And sir is a former professor and head of Department of Surgery at JSS Medical College, Mysore. He is the immediate past president of the ASI, that is Associations of Surgeons of India. We are pleased to have you, Dr. Siddesh. Next,
Thank you.
I would like to also introduce to you and invite Dr. Tadeja Pinter. She has done her master's degree and doctor's degree from the University of Ljubljana in Slovenia, where she is currently also the assistant professor in surgery. She has more than 150 publications to her credit, and she has been actively involved in endoscopic work and has been an important pillar of strength in TUGSS endoscopy. I'm pleased to invite, and we are all happy to have you on board. Over to Dr. Balla again.
Okay, so it's now my distinct pleasure to introduce our guest speaker for today's session, Mr. Brij Madhok, who is a consultant bariatric surgeon at Royal Derby Hospital and honorary assistant professor at the University of Nottingham. Professor Madhok is the current president of the Upper Gastrointestinal Surgical Society and has extensive experience in bariatric surgery and endoscopic weight loss procedures. So thank you, Dr. Madhok, for joining us today on this Sunday morning. I would request you to start your presentation now. The screen is yours.
Bhavneet, thank you so much for the kind introduction, and it's a pleasure to be here today. So I'll try and share my screen, and that should be visible now. And is that clearly visible now? Or is this not full screen yet?
No, I think it's full screen.
Full screen?
And,
Okay.
yeah, and the audio video are good.
You can switch on the slideshow from the near the Zoom button.
So have I not done that? Hang on. And
it's anyway visible, but yeah.
Yeah, so I thought I had done that.
You can start.
Yeah. Okay. So thank you so much. I'm really honored to be invited here to talk about intragastric balloon, which I have been doing for the last about 3 years, and I have found it's a really good addition to what I can offer to my patients for when they come for the option for weight loss. Before I start, I'll just apologize. I'm just recovering from a bit of flu and cold and cough, so I may cough here and there. So I do apologize for that in advance. So Bhavneet, as Bhavneet said, I am a consultant surgeon at University Hospitals of Derby and Burton, and I am a trustee for TUGSS. And I think Bhavneet has already spilled the beans that I am elected to be the next TUGSS president. So that's a huge honor for me. So without further ado, I will just, this is, again, as Bhavneet very kindly said, this is what we'll try and cover. I'll give a bit of history about intragastric balloon because I think That's important for any procedure that we are doing or intend to do, to have a bit of history about it. I'll try and cover the different types that are currently available. And I would explain that the ones that I do, I don't do all of them, but I do a couple of them, which will cover the spectrum. I will briefly try and cover the evidence, and you will see that the evidence for use of intragastric balloons is massive, and probably we cannot cover all of this in this forum today, but we should be able to have a brief overview. Um, and then I'll touch on the indications, contraindications, patient selection, and what are the complications that we need to be aware of, inform our patients, and aftercare, which I think is absolutely crucial for these patients. Sorry. So a bit of history about intragastric balloon. So intragastric balloon has been around for uh, quite some time if you look at it. So uh, the first proper balloon was devised and used in 1985 in the US, and this was by a gastroenterologist couple, husband and wife. And this was called as the Garen Edwards balloon, which was cylindrical shaped, a bit more like the tin of Coke or Sprite that we get as of now. And it's air filled, and this got US FDA approval. However, there were huge problems with its use. So complications were high, risk of gastric erosions, bleeding, intolerance. It was way too high for it to be clinically acceptable. Around at the same time, in the UK in 1985, the Taylor balloon was being developed, and that was pear-shaped. Not sure why that was chosen, but things didn't go very well for that balloon. And around 3 years down the line, in Denmark, an oval-shaped balloon was designed called as the Bellops balloon. So that's a bit of a history when these were these different shapes of balloon and different kinds of balloon were being trialed. Um, So, as you can see, because of the huge demand, there was there for the balloons. Now, look at what I'm talking about. I'm talking about 1987. And as we all know that obesity has, as a disease, it has become much more prevalent now. We have much more patients suffering from obesity and being overweight. But even in 1987, the demand for this procedure was huge. But there were high rates of complications and side effects, and that led to this expert consensus meeting in the US. And this was attended by a variety of multidisciplinary persons at that time, surgeons, gastroenterologists, nutritionists, radiologists, everybody was involved in that. And about 75 international experts were called upon. And this is what they came up with. So they said, what will be the ideal balloon be like? And the agreement was that it should be spherical, made out of silicon, which is the most inert material, as we all know. We use it a lot in medicine. It has to be smooth to reduce the friction and reduce the when it is within the gastric lumen, to have irritation on the gastric mucosa. Ideally fluid filled, and it should be adjustable as much how much fluid can be inserted. And the agreement was somewhere between 400 to 500 mils would be ideal. And also it should have a radio opaque marker, as that will make it visible on radiological imaging. So based on this, a few different balloons came into a clinical practice, and one of them is this one called as the Reshape Duo. As the name suggests, Reshape, it mimics the shape of the stomach. And this has in fact got two balloons, which are both filled up with fluid, each containing 450 mils. It does require endoscopy both for insertion and removal, and it can be left in the stomach for 6 months. I don't have much experience with this balloon, but it is available in the clinical practice. The other one, which kind of was developed straight after the consensus meeting in 1987 and came into practice in 1991, so it's been around for quite some time, is the Obera balloon. This is designed by Apollo Endosurgery or maybe Boston Scientific now. But this kind of met most of the criteria for the ideal balloon that the consensus suggested. So it was spherical, it is smooth, it is made out of silicone. It can be adjusted, the volume in it can be adjusted from 500 to 700 mils, and it is fluid filled. And initially, when the balloon was used and marketed, the company said it is a 6 month balloon. But I think in the last 4 or 5 years, they have done further R&D, and now the same balloon can be left up to 12 months, although the program is a bit different as to what aftercare they receive. But it is safe to be left up to 12 months. It does require endoscopy for placement and removal, and time permitting, I'll share a brief video about that towards the end. And more recently, the SPATS-3 balloon has been used. This is, again, it's a spherical balloon made out of silicone and saline filled, and it can have up to 700 mils as well, fluid volume wise, and again requires endoscopy for placement. Can be left between 8 to 12 months within the stomach. The main advantage of the SPATS-3 balloon is that it is adjustable. So as you can see, it has got a catheter attached to the balloon, which can be pulled out after the balloon has been placed, and fluid can be removed or inserted after the initial placement as well. So, for example, if we place the balloon and the patient is not tolerating the balloon very well, vomiting is a major side effect, then you could go back in endoscopically and remove some fluid. Also, other way around, if the patient is not experiencing enough weight loss or enough sensation of fullness with the balloon, then you could, a couple of months down the line, you could go back in and then refill the balloon as well to some extent. The downside is that it's not smooth. And there is some chances that it causes more irritation to the gastric mucosa and risk of ulceration. Moving on to the swallowable balloons. So there is this balloon called as Obelon, which is the placement is swallowable. So it does not require endoscopy to insert the balloon. And it is gas filled up to 250 mils, and up to 3 balloons can be placed a month or thereabouts apart. However, it requires endoscopy to remove all the 3 balloons, and maximum they can stay for 6 months. And again, I don't have any experience with this one, but I do have some experience with this Allurion balloon. So Allurion balloon, I think has been around for the last 7-8 years now, or maybe a bit longer. This is again a swallowable balloon. So the patient swallows this capsule. I don't know if it is visible. And they compare it to this, which is like a 20p size coin, which is not that big. And most of the patients will tolerate it just about fine with a glass of water. And the capsule is attached to this catheter, which is radio opaque. And what is done is once they swallow it, with the markings, you can know whereabouts is the capsule is, whether it has reached the esophagus now and whether it has reached the stomach. And then a plain abdominal X-ray is done to confirm that the capsule has reached the stomach. And once it has reached, and this catheter is used to fill 550 mils. It's a fixed volume of liquid. The liquid is also provided by the company, and then this capsule turns into this balloon. So again, it's spherical, smooth, made out of silicone. This balloon lasts for 4 months. Okay. What happens at the end of 4 months is this balloon is held up in position by a stitch. The stitch dissolves and the balloon becomes like a very small plasticky film, which the patient will pass naturally. So the beauty of this balloon is that it does not require endoscopy for placement, and it does not require endoscopy for removal either. And it's a very quick, it's advertised as a outpatient procedure, so it does not require endoscopy, does not require sedation, nothing of that sort. Patient can just walk in and walk out of the clinic. So these are the type of balloons. The other one, which I have not covered here, is the heliosphere balloon, which is placed endoscopically, and it's an air-filled balloon. Again, as of now, I don't have much clinical experience with it, but it is, I understand, available in clinical practice, and there are a few studies on that. So obviously, there are a lot of, at least 6 different types of balloons available, and anybody who would be interested in reading about them, I would guide them towards this nice review published in the World Journal of Gastrointestinal Endoscopy. I mean, it's fairly obvious, isn't it? How does the balloon work? So it works, first of all, by occupying most of the space in the stomach. So typically, the balloon will occupy um, a third or 1/3 of the space in the stomach, and thus making the patients feel full. There is some evidence which can be questionable, that because it stretches the stomach wall, it may lead to reduced ghrelin levels, which we all know is the hunger hormone, and hence may reduce the feeling of hunger in the patient. But there is plenty of evidence to suggest that the balloon within the stomach delays gastric emptying. Okay. The idea here is that the patients will eat smaller portions, and whatever they eat also stays in the stomach for a touch longer than normal, and hence they can overall reduce their portion size. One thing is that the balloon is completely reversible. So this is very important when we tell the patient it does work, but you have to work with the balloon to make the changes in their diet and lifestyle. Because if they don't do that, yes, they will lose weight, but likelihood is once the balloon is out, they can put all the weight back on. So that's a crucial thing in patient counseling. So if you look at the evidence now, when I started looking into this, I found that this is one area of weight loss surgery or weight loss therapy, which has been extensively studied. Look at the number of studies. There are at least 20 RCTs. There are multiple clinical studies which are not randomized trials, but still important clinical studies with thousands of patients involved. Okay. Now, most of the patients are, they have received the Obera balloon because it has been around the longest and is still going strong. However, more recently, the Allurion balloon has been used in quite a few studies and trials as well. And again, this is a nice meta-analysis, so level 1 evidence and systematic review by Roll Rosenthal group to look at the efficacy of intragastric balloons. So I would guide the attendees there to have a bit of overview of the efficacy into intragastric balloon. What overall I could gather from the evidence is that the air-filled balloon is better tolerable than a fluid-filled balloon. So the symptoms of side effects of nausea, vomiting are less. However, the fluid-filled balloon may result in a better weight loss than air-filled balloon. The weight loss does vary from a person to person, as with anything, but the typical range that is found is 10 to 20% of total body weight loss. And most of this weight loss will happen in the first 3 months, but the rest of the time is there for the patients to work with the balloon and make sure that they have made changes in their diet and lifestyle. One thing is there, I only found one or maybe two studies showing the long-term results after gastric balloon. So there is a bit of lack of long-term results following gastric balloon in the current body of evidence. I would like to share this study. This was kind of a landmark study for Obera. published by Galvio Nato, who is quite an experienced bariatric endoscopist, world-renowned. And he published a study from Brazil, around 40,000 intragastric balloon cases. And as I mentioned before, the mean weight loss that they found, total body weight loss, was around just over 18% in 6 months. And look at the removal rate. So the removal rate was really low. That is the early removal rate, only 2%. And this is clearly very low, very, very good profile. And again, the safety profile is around 2% adverse event. And if you read this paper, the more you do these balloons, more experience you have, you're likely to reduce these numbers even further. So overall, this study with this massive number of patients supported that the balloons, use of intragastric balloon is safe in clinical practice with a very low risk of morbidity and mortality. Now compare this to what I showed in the first slide, 1985. We were having a lot of problems with these complications after gastric balloon, and fast forward 30 odd years, and we have this fantastic study showing really good results. So it has come along a long way since the initial idea of intragastric balloon was there. Now, this is where I see intragastric balloons will be most useful is patients with BMI less than 35, so patients with class 1 obesity. And there is really good evidence to support use of intragastric balloon in this group of patients. And these are the 3 studies which I found really helpful. The first one where they have compared, published in the European Surgery, they've compared different BMI groups, and they find that patients with the lower BMI benefit more with intragastric balloon, and similarly with the other 2 studies. And this study published by Daniel Chan, this is one of the few studies which has shown 10-year follow-up. It's a randomized trial, although the patients' numbers are small, but this is where they have shown 10-year follow-up after intragastric balloon. And the 10-year results are not that good, and they have compared it to control group, and they are similar, but it does help the patients along the line. And certainly the weight loss is maintained for at least 2 years since the balloon is removed. And at 10 years, although the patient may put some weight back on, but they are more agreeable to have further interventions, because they have had a good result, successful result with one therapy. The other thing is, as we all know, it's not just about weight loss with bariatric and metabolic surgery. We are more worried about improving patients' comorbidities, especially type 2 diabetes. So a good evidence to suggest that use of intragastric balloon improves these comorbidities, especially improves the HbA1c levels. It improves the lipid profile, improves the blood pressure, as well as impact on the fatty liver. Now, the non-alcoholic fatty liver disease is something that has gained attention a lot recently, and certainly my hepatologist colleagues up and down the country have got a lot of interest in it, and probably it's because of this. So both of these studies are recently published in 2023, and both showing that use of intragastric balloon can improve the impact of non-alcoholic fatty liver disease by reversing the steatohepatitis and the fibrosis within on biopsies. They have showed improvement in liver enzymes. They have showed improvement in portal pressures. So the evidence is real. And this one here on the right is in fact a meta-analysis. So I would urge attendees to review this as well. I think it's a really good evidence on how it can have an impact on non-alcoholic fatty liver disease, which affects almost 25% of population. So hopefully I've convinced everybody that the intragastric balloon does work. However, this is the main question that comes to everybody's mind, I guess. What happens after removal? So there are few studies showing the results of how patients are doing at least a year after removal. And it does show that yes, patients do have some weight regain, but majority of them still keep the weight off. They still have improvement in their HbA1c. They still have improvement in their lipid profile, and they have made changes to their diet and lifestyle. They find themselves to be a bit more mobile. They're able to do things that were struggling before. So at least a year after removal, we've got good evidence to support the use of gastric balloon. I'm not sure, as I discussed, about the evidence after that. So if we come to indications and when do we think an intragastric balloon can be used? So these are the current indications that we have. So it could be used for BMI more than 27. However, recently Obera was changed and they now advocated for patients with BMI more than 30. It can be used to initiate the weight loss. And as I mentioned before, which I cannot, emphasize more strongly, is that it has to be used with the diet and lifestyle modifications, without which patients may not get the optimum result. The second thing is where it can be used is to avoid major surgery for maybe for young patients who may not want to go through the major operations and the risks that come along with it, and that they are that completely irreversible operations. So patients who want to avoid that, or we as practitioners may want to avoid that major surgery in a particularly higher risk surgical candidate. So this is where balloon could come in handy. And I've certainly had a lot of experience with using them as a bridge to surgery. So, for example, you have a patient with a BMI of 70, 80. We all know that doing a gastric bypass or a sleeve gastrectomy in such a patient can be technically very difficult. You can help patients to lose weight with use of gastric balloon and prepare them better for a safer outcome with surgery. So these are the current indications that I see. I certainly see patient for class 1 obesity, which is the first one, BMI more than 30, balloon will have a bigger role to play. However, we have to be careful because not everybody is suitable for a gastric balloon. And I have put them as two in two columns. One is the absolute one, which I think we have to abide by, whereas the relative one is something that you can adapt practice, change the medications that the patients receive, and you may still be able to use a gastric balloon. So any previous gastric surgery is a complete no-no. Okay, anybody with a previous fundoplication, certainly previous bariatric surgery, they cannot have a gastric balloon. Anybody with a giant hiatus hernia. So by giant, I would say more than 5 centimeter hiatus hernia, we should not use a gastric balloon. The risk is the gastric balloon may lodge within the hiatus hernia and may cause disastrous dysphagia and complications. If the patient has got an active bleeding lesion in the upper GI tract, so this does not mean that patient has got active symptoms, but if when we do an endoscopy and we find that there is an ulcer, could be absolutely benign, but or any other bleeding lesion like a mucosal vascular deformation, we should not use a balloon in that case. Okay. Patient has got any coagulation disorder, I did mention about liver disease, but advanced liver disease where patient develops coagulopathy, I don't think we should use a balloon because they're at risk of life-threatening bleeding. Equally, pregnancy. So we are very clear that patients are not pregnant when we speak with them, and they have to avoid pregnancy for the duration of the balloon therapy. Okay. And if they do get pregnant, then it leads to an early removal. Usually the second trimester is when I prefer. Then I will talk about some relative contraindications. And as I said, hiatal hernia is relative. So if I do an endoscopy and I find that there's a small sliding hiatus hernia, say about 2-3 centimeter in size, and I am happy that I can easily insert the balloon within the stomach, distal stomach in the body, and not within the hiatal hernia, then I will go for it. So that's not a problem. These patients may experience a bit more acid reflux, which may need to be controlled with a higher dose of PPI therapy. Previous abdominal surgery. Now, this is an interesting one. So, if the patient has had multiple major abdominal surgery, then I would avoid gastric balloon totally. Whereas if they have had, say, a previous midline laparotomy or some other surgery, then we could still use the endoscopic balloon. Sorry, I'll just mute myself for a minute. I do apologize. So if they have had a previous major surgery, then I would avoid the swallowable balloon, the Allurion balloon, which the patient is supposed to pass naturally, because these patients may have adhesions, and the balloon may, when they're about to pass it naturally, it may cause bowel obstruction. Whereas you may be able to use the endoscopy balloon, which you place endoscopically and remove endoscopically. Previous laparoscopy is okay. So if they have had previous laparoscopic cholecystectomy or laparoscopic appendicectomy or some kind of laparoscopic gynae surgery, they are okay to have balloon therapy. Cesarean section is not a problem. Hysterectomy is a difficult one. I'm very careful, patients with open hysterectomy, offering them the swallowable balloon, but the endoscopic balloon is fine. Any patients with swallowing difficulty, so if they have got significant dysphagia or esophageal motility disorder, we may have to be careful there. And again, if they do need a balloon, I would do the endoscopy one, because you can check that everything is okay, then use the endoscopy balloon. Whereas this swallowable balloon, we don't have the luxury of endoscopy. Gastroesophageal reflux disease, if they have got significant acid reflux along with or without evidence of esophagitis on the endoscopy, we have to take clinical decision as we think whether the patient will survive the balloon therapy with additional dose of PPI therapy, or we think we rather not do that. Or the option is treat the acid reflux with higher dose PPI and for say 6 to 8 weeks, and then bring them back for reassessment and then balloon therapy. So that's why I've put them as relative. Okay, so this can be amended as per the clinical situation. Gastroparesis is a difficult one. So a lot of the patients who come for balloon therapy have got type 2 diabetes. Long-running type 2 diabetes may cause gastroparesis. So this may require clinical judgment, decision-making as to whether this patient may be suitable, because gastroparesis may increase the risk of the symptoms of nausea, vomiting, and eventually lead to balloon intolerance. So that is something that we may have to judge. I would be careful in anybody with type 1 diabetes, and I've done that once, but the patient could not tolerate it. They are at risk of not only gastroparesis and balloon intolerance, but going into ketoacidosis. So that decision has to be taken very carefully. And somebody with chronic steroid use or non-steroidal use, it depends what they're using it for. Non-steroidal, most of the patients are happy to leave it when they have balloon therapy, whereas chronic steroid will be for a more serious condition, and they may need extra PPI cover. So how do I assess a patient when they come for balloon therapy? So it goes without saying, it's like any other clinical consultation, we take a detailed history from them. What are the patient's demographics? What kind of previous attempts at weight loss they have had? And mind you, most of the patients who come to us for balloon therapy, they have tried a variety of different diets and options before trying this. Um, Psychology or psychiatric history is important. We want that the patient is in a stable mental health point of view. They may be on some medications, but so long as they are on those medications, have been stable, that's not a contraindication. But active disease, active mental health issues can be, and they may need extra support through psychologists. So if they do need that, then we have psychologists in the team who will offer that support. Smoking alcohol is important, so I actively discourage patients not to smoke during the balloon therapy because just to try and minimize the risk of gastric and esophageal ulcerations. Okay, alcohol history as well. Patient can have a drink, but if they do, they have to realize these are all empty calories, and if they have increased alcohol intake during balloon therapy, it may have an impact on their results from the balloon because they may not see the optimal weight loss. Previous abdominal surgery, I've discussed in the contraindications, so we need a detailed history of what previous surgery the patient has undergone. Um, and we have to stress this time and time again with the patient that they should be ready to make the diet and lifestyle changes. So I, at least, 5 minutes of my consultation is explaining them what kind of changes I'm expecting them to make, because simple things patients don't sometimes realize that that's what they have to do. So one of the common things I tell my patients is they have to take their time for their food. They have to eat slowly, chew it very well. And there's a very subtle time where they will have this, sensation of fullness. That is when they have to stop eating. In terms of preparation, so we start the patients on proton pump inhibitors 2 weeks before the balloon is to be inserted. Okay, so we give them omeprazole 20 milligram once a day, and we give them antiemetic as well on the morning of the balloon placement. So we use something called as aprepitant by the trade name Emend here. So we give them one tablet of that in the morning, and sorry, I'm just going to mute again. And they also receive ondansetron along with the aprepitant after the balloon therapy. And this is more important in the first 2-3 days when the patient is having initial side effects, I would like to call them, of nausea and vomiting. During this time, I also advise the patient just to stay on liquids only, something like simple water or some squash or juice and things like that. And once the symptoms settle, then they progress. So it's all hunky-dory, all good as of now, but then obviously these things happen. So it comes to complications. And luckily, the risk profile is much, much better now than what it was, say, around 30 odd years ago. So nausea, vomiting, acid reflux, abdominal pain, which is like cramp-like spasmodic pain, very, very common. So I warn all the patients about it, and I think 2 out of 3 get these kind of symptoms, and that's why the medications are important. As I said, the pre-medications are important, as well as the post-medications after the procedure are also very important. One thing I try and avoid is use of Buscopan. Okay, so Buscopan can be good for the spasmodic pain, but there is some data to say that it may increase risk of intolerance. And hence I would avoid Buscopan if they can. Simple paracetamol is advisable for pain relief. And if that does not help, then they can try the Buscopan, but try and minimize use of Buscopan. The main thing that the patients worry about is, and me as well as clinician, is intolerance, because a lot of patients, come privately for this procedure and they have paid quite a bit of money. And if intolerance happens, which can happen in up to 2 to 5% of patients, then this balloon, the balloon that they've had, needs to be removed, and that is a lot of money down the drain for the patient. There is a risk of insufficient weight loss. So I did say about 10 to 20% is the total body weight loss that results we share with the patient. But it's important to tell them that some patients may lose less weight than that. But equally, I have had patients who have lost more weight than that as well. So this kind of counseling has to happen with the patient during the initial consultation. Obviously, we are all endoscopists, so we know what are the risks with endoscopy, and they hold true with the balloon as well, especially the ones we're using endoscopy for. So these are common ones that I see on the left, and these are quite rare. So perforation, I would say that's pretty much like any diagnostic endoscopy that you may see. So it's very, very rare. Risk of balloon rupture and migration, it's very rare. Okay, so this is the question I get asked a lot by patients, that what is the risk of balloon rupture? These balloons are robust balloons, have gone through extensive R&D, extensive technical tests. And if you search YouTube, I'm sure you'll find somebody doing some kind of yoga exercise on the balloon or even standing on the balloon, okay, a human, and the balloon does not rupture. So it's a very robust balloon. It does not rupture like that. What I do want the patient is to avoid direct trauma. So if they sometimes do kickboxing or karate or whatnot, avoid direct blunt trauma to the upper abdomen. And the patient should not do deep sea diving. Okay, if they do it sort of for leisure deep sea diving, even that is allowed. But these are the activities that may increase risk of balloon rupture, and once it ruptures, then it can migrate distally. Small bowel obstruction is rare, especially if we are thorough with the patient selection. So as I mentioned, anybody with previous abdominal surgery, be careful in offering them this swallowable balloon, which they're supposed to pass naturally. Other things, hyperinflation, quite rare. We have to practice asepsis when we insert the balloon. And if we do that, then risk of infection and hyperinflation is generally quite rare. Gastric obstruction, gastric outlet obstruction, a possibility. But again, if you place the stomach within the body carefully, not in the distal antrum, then that migration generally does not happen. And whenever patients have come with gastric outlet obstruction, I think it's more intolerance, because the balloon is actually quite mobile within the stomach. So even if at endoscopy, when you go in for removal, you find that the balloon is in the antrum, the balloon is quite mobile, so it may keep on moving from antrum to body and fundus and thereabouts within the stomach. Pancreatitis is quite rare. It's a small possibility. Most of the pancreatitis that happens after balloon therapy are the mild versions. Okay, it happens in the first week because of the pressure from the balloon on the pancreas, and if the patient is clinically well, the balloon can be left in situ. So if the patient has a mild episode, raised serum amylase, some abdominal pain, but gradually clinically gets better, then the balloon can be left. However, if the patient shows signs of worsening, or the vomiting or the nausea does not settle, or there are other side effects of pancreatitis like acute kidney injury or so on, then obviously it's safer to remove the balloon early. Fungal infection on the balloon is very common, but most of the time we just find it when we go for the standard removal. So often it does not cause major problems. As I said, gastric and mucosal erosions are possible, and that's why I think it's important that the patients continue on a standard dose PPI therapy throughout the time they have the balloon. So I keep my patients on omeprazole 20 milligram once a day throughout the, say, for example, if they're 12-month balloon therapy, throughout the 12 months they receive omeprazole. Mortality is very, very rare. And this data is from around 300,000 patients. Generally mortality is very rare. At worst, they have to contact the clinical team when they develop any of the aforementioned complications. And once they're dealt with appropriately, mortality should be very rare. So obviously, there are, if you look at the evidence for serious complications, it is out there as well. And once these happen, this kind of question does arise: is that the device, is that the patient, or doctor to be blamed for the complication? I think it can be a combination of either of the three, but as I said, if you practice it safely, it is generally a very safe procedure to offer. Okay, and this is again a big, massive study over close to 6,000 patients looking at complications and efficacy. So again, a good read to understand the balloon therapy, how to offer it in a safe fashion. I said the aftercare is very important. So first of all, it's very important to tell the patient that, the balloon is not a magic bullet. It's not a magic balloon. You'll have to work hard with it to achieve success. I've discussed the antiemetics, which are very important in the first 2-3 days, and the patient should receive this religiously. PPI therapy, throughout the period, the patient has the intragastric balloon in situ. And as I said before, only clear liquids, small sips for the first 2-3 days. And once that settles, then there is slow progression from there to liquid diet. And once they're keeping liquids okay, then to solid diet. And that typically happens within the week. In my clinic, we offer them regular dietitian and nurse follow-up in the first month. And this depends upon how often they need. So it's tailor-made to the patient. Some patients progress very well and they just need one follow-up call. Others may need a bit more, but then they receive at least a monthly dietitian review till the balloon is out. So this kind of aftercare is important. We also have designed, at the beginning we were talking about how Parth is so good with the technical side of things. So we have designed apps and all that patients really like, and they have been custom made based on previous patient experience, like dietary options, what kind of meal options they could have, and so on. So I don't know whether we have time to run a video, Parth, Bhavneet, is that okay? We got enough time? Not heard from every
Yes,
side.
yes, yes, sir, we can go
Yes,
ahead.
please go ahead. Please go
Okay,
ahead.
all right, yeah.
We'd love to
I'll
check.
play a brief video. This is me doing the procedure, and I said I will just show it to show essentially what is the kind of setup. I don't mean to train anybody with this by looking at one video, but the idea is to show you the setup. Now, I do most of my balloon under mild sedation. So this is an endoscopy one. I didn't get to manage to take a video of the swallowable balloon, but the swallowable Allegiant balloon, there are plenty of videos available on YouTube and other social media, which can easily be done. That's very simple to do, I think, for any surgeon or endoscopist. It's more like placing a nasogastric tube, in my opinion. So long as you are careful, it's the patient selection, and so that is more important than the aftercare. And the endoscopy, quite a few of my colleagues do it under general anesthesia in operation theater. I don't think that is needed. Most of the endoscopies, just like diagnostic ones, we do it under throat spray, some lignocaine throat spray, and mild sedation. What I use is midazolam and fentanyl. So these are the two I combine. So let me try and play this. Oh. Okay. So that's the setup. So there's some noise in the background, but I'll just explain to you. So the patient, as you can say, she is in left lateral position, and the patient is moving. The nurse is there at the head end, who is telling the patient to move and be comfortable in the left lateral position. I've given mild sedation, as I said, with midazolam and fentanyl, and just doing the initial endoscopy check, which is standard endoscopy. Go till D2, do a retroflexion, make sure there is no contraindications as we discussed, like a big hiatus hernia or a bleeding lesion that may preclude placement of the gastric balloon. One thing is, once I do that, you will see the nurse in the background there opening the balloon. and I only get them to open the balloon once I've done the endoscopy and I'm happy that the balloon can be placed, because the balloon is expensive and you don't want it to be open and laid out there for you. And then you find out, hang on a minute, we can't insert the balloon for this patient. Once that is done, this is the actual balloon. So it comes in nicely folded within the film, and plenty of lubrication to get the balloon down. Okay. I use a lot of any aqua gel for it. And the balloon, I must say, is placed blindly. But as I said, it's like placing the orogastric bougie that the anesthetists do for the operation. It goes down all right. You will realize when it is going down the cricopharyngeal sphincter, even when it's going down the esophagus. What I would say is that if it's not going down, it's not sliding down smoothly, don't push too hard. Just leave it where it goes until, and then you can do an endoscopy, which I'll be doing now. Um, and then you can push it in direct vision. I'll pause it here just to show this is the bag of saline. So I mix it with methylene blue, and that's why it's looking, that color. And it's a liter of normal saline with 5 mils of methylene blue in it. And the giving set, which is attached here, comes along with the balloon. So the giving set is introduced, and the nurse here has kept it ready. She takes a 50 mils Luer lock syringe and withdraws that 50 mils into the syringe through the giving set and keeps it ready while I am doing all this business and checking the balloon. Okay, so that's all happening in the background. So now I would do the endoscopy, and the scope will pass easily next to the balloon tubing. It's quite easy. I do apologize for the quality of the video, but as I said, I want to show the full setup. So I'm just slowly getting in. And once I'm in, you may be able to see the tubing of the balloon. I don't know whether you can appreciate. There is a bit of a a bit of plastic tubing there, which I'm just following that. And this is distal esophagus, and that's the GOJ. And there I'm into the stomach, and that's the balloon. So now I've confirmed that the balloon is nicely in the body of the stomach. That's where it should be. And once I say go ahead to the nurse, she is starting to fill it up. And I fill it up under direct vision. What you're checking for is that the balloon is intact, it is not leaking. The methylene blue filled saline that you're injecting is slowly filling up the balloon. And I use generally about 550 mils of this liquid to fill up the balloon. The balloon is filled up now. And then once the balloon is filled up, the catheter, you can just see I've withdrawn and the catheter comes out safely, but my endoscope stays. And now I'm going to check if there is enough room around the balloon to pass the endoscope into the distal stomach. So I know that it is not going to cause absolute obstruction, and patients should be able to manage liquids initially and then eventually solids. And the final check is to make sure the balloon is definitely in the stomach, not in the distal esophagus or anything, which will be disastrous. So I'll end it there. And that's the summary, if I may. So I think it's a really good non-surgical weight loss. And I think in terms of whereabouts does it stand, I think it stands somewhere in between the dietary modifications and the medical treatment that we have more and more available now, and bariatric surgery. Certainly more important for, say, patients who want to avoid surgery or patients with class 1 obesity. Important thing is completely reversible. Okay, it's got an excellent safety profile, hopefully with the evidence that I've shown you that is confirmed. And certainly in my practice, I would say hand on heart, it's a really safe therapy to offer. Important thing is it has to be offered within the bariatric program. Okay, so you need to have work with the dietitians, work with the specialist nurses, work with the as I said, if required, the psychologist to offer support to the patient. Patient counseling and assessment is very important. One thing I would say that not for weight maintenance. So weight maintenance will be down to the patient to make the changes, in the diet and lifestyle, and then continue with that once the balloon is removed. And I think that's my final slide. However, the most important one, which I feel is here. So if I can have just 1 minute to talk about TUGSS to all of you. So as we all know, I think Bhavneet and Parth have been doing brilliant job with TUGSS endoscopy, and TUGSS is now an officially registered charity. You can find more details on this website or on Twitter. And there are going to be exciting times in terms of education, training, research, collaboration. So please do get involved. Please do join us. And there is be the full membership, which there is a bit small amount of fees that is involved now for full paid membership. But if you would like to keep the membership free, the affiliate membership would be available to you as well. So please consider that. Thank you so much.
Thank you, Dr. Brij, for that excellent and wonderful talk. I think you have covered almost all aspects of balloon in detail, and I thoroughly enjoyed. I'm sure everybody has enjoyed this talk of yours. And before we open the session for the Q&A, I would like to invite our chairpersons for their comments. Dr. Siddesh, Dr. Pinter, would you
Yeah,
like to go first?
yeah, that Mr. Madhok, you have done a wonderful job. You have covered obviously everything what is there to this covered as a subject, and I'm sure any beginner would have got a complete thorough information how to begin with, how to select the patient. As you all agree, today the most important thing about this procedure is patient selection. So proper patient selection, if it is well indicated and you go through the algorithm what has been put forward by Dr. Madhok, keeping in mind the contraindications, I feel this procedure is absolutely safe, keeping in view majority of the audience who are looking up to get this guidance from this talk are all surgeons. And for surgeons, this should be a real easy procedure even to a beginner. And I only say, please stick to the points which have been put forward to take care of avoiding all those contraindications. And my only question to Dr. Madhav could be, how do you tackle those patients who would continue to require anticoagulant therapy or antiplatelets, those who are taking? Would you alter them, or would you watch them closely after placement, or you ask them to take some precautions when you do this procedure on them? That is one. And number two, of course, this mentoring, telementoring, what we have gone through today, is it enough for a surgeon who has the basic knowledge of endoscopy to begin with his procedure, provided he observes all the etiquettes? So these are my two questions, if you can. And I would really appreciate you with that bit of ill health, you still continued to really be very candid and very clear about what you have spoken to. Thank you.
No, Dr. This, thank you so much. I'm really honored to hear this words from you. So really appreciate it. So in terms of the anticoagulants, antiplatelets, so I think that would be absolute contraindication. So if they need anticoagulants, especially, even if they are the newer ones like apixaban and whatnot, I would not risk it, because the problem is, it's not like you can, as we do with surgery, you could stop it and then restart it, but then you don't know. You see, even if you restart it, what are the risks? There are no clinical studies on it. And if we do that and if the patient starts bleeding, it's going to be a disaster, isn't it? So if they have a stomach erosion in the mucosa and they start bleeding, it'll become a acute emergency. So I would say anticoagulants, definitely no. Antiplatelets, if it is again something like clopidogrel, I would avoid it, because these are important medications. Patients need to be on those. So completely avoid it, especially if you are starting new. Don't do balloon therapy for these patients. Aspirin is a different one. If sometimes patients are on aspirin just as a primary prevention of ischemic heart disease and so on, then that's fine. They can stop it a week before, and if acceptable, then I would say leave aspirin during the balloon therapy completely. Okay. But if it is aspirin is because they've had a previous MI or a stroke and it's important for them to continue aspirin, I would still avoid balloon therapy if the patients need aspirin. Play it safe is my advice. Okay. And sorry, what was one more question about? Yeah, so I don't think this is a training program at all. So this is just the initial kind of brief introduction about balloon therapy. Anybody wanting to start offering these balloons to their patients, I would say do your own research. I'm happy to share these slides out. They can be emailed out to all the attendees, and to the TUGSS, or anybody who wants to get involved. They can read through the evidence that I have done, or they do their own research. But it's important to have, as you said, mentoring is important. So I would say visit a center who does this balloon therapy. And when you're doing your first few, have somebody over to watch you doing it. And these things are crucial, because if you have a complication in your first, say, 10 balloon procedures, it will hit your confidence and you will not be able to restart. So it's important to start slow. So this is just meant to be a brief introduction. The video, as I showed you, is just to say it can be done safely, just like a normal endoscopy, but you have to go through that whole process to be able to deliver the program safely.
Thank you, Madhok. I think you have been very clear, and that's exactly what I anticipated you to convey the message to the juniors. So I remain. Thank you.
Thank you so much, Dr. Siddharth. Thank you.
So it's my turn now.
Yes, Tadea.
So thank you very much for a very nice presentation, very clear. But besides everything you mentioned, I have some questions in terms of the increasing incidence of fatty liver disease also in lower weight groups. Can we suggest to start or this is a clear indication for balloon placement? If there is no clear indication for metabolic and bariatric surgery, as we all know that this might be an indication for this type of surgery in a group of patients with advanced liver disease, metabolic liver disease.
So today, I think the patients, the studies that I shared is patients who are at least overweight or with class 1 obesity. So I presume your question is if the patient's weight is not, the BMI is less than 25 and they have non-alcoholic fatty liver disease, then can we use balloon therapy? Is that what you're asking? Sorry.
Yes, a part of question is...
Yeah, I think it's difficult to justify that, isn't it? Because there may be a bit more metabolic. I mean, I have very limited knowledge about liver disease. I don't claim to be a hepatologist, but there may be other reasons for them to have that liver disease, isn't it? But if they have, weight issues along with fatty liver disease, which most of the patients do, then I think balloon therapy is what we are talking about. Is can be justified.
The other question, you talked about very high BMIs, but the balloon may be a stage to come to bariatric or metabolic surgery. Yes. But how can we advise our colleagues for syndromic patients? What is the situation in them in compulsive eating disorders? Do we have to avoid the balloons in syndromic, for example, rather we leave it?
So patients with, like, says, who have like binge eating disorders or yes.
And
So
high.
I think, to be honest, my take on that is obviously they need to go through full psychology and psychiatric assessment. There's no, sort of way we can avoid that. But if they have support from the psychology team that they are in a good mental health situation to go through it, before we embark on something like completely irreversible procedure like a bypass or a sleeve, I think it's balloon is safer, isn't it? So you can give them the balloon therapy, and say, for example, if they do not cope with it at all, then it's completely reversible. You have to just remove the balloon for them, and no harm has been done. So I think it's a good trial. If we give them the 12-month balloon, it's a good trial to know how they would deal with when they face with restriction.
Do we have to conclude that this type of patients should have a stronger follow-up?
I would highly recommend it. Yeah, I would highly recommend it. I think not only with the surgeon and the dietitian and nutritionist, but maybe the psychology team as well. Whenever I do them, I have the psychology team, going through them, months before, multiple assessments. And once they tell me that they're absolutely good to go, only then I would do the procedure. And you're right, after the procedure, I would get them reviewed by the psychologist, more so in the first month when they are going through symptoms and change in diet and whatnot, just to, pick up clues, if they are not doing very well, then we rather know that early. So I absolutely, yeah, I would agree with that today. Yes.
What this is my last question.
Fine.
What about the range of metabolic effect comparing metabolic bariatric surgery and intragastric balloon? For example, would the balloon be enough for a patient with advanced liver disease? Because there we can expect improvement after at least 20% total body weight loss. It is to discuss a little bit about this because as you mentioned, the balloon offers on average 20% total body weight loss. This might be the initial of the journey of improvement of liver disease. How can we conclude?
So no, I think again, I completely agree. And as I said, this is just the initial weight loss that the patients will get. The results that we have is up to a year, right? So we have we show that once we have removed the balloon and we follow them up 1 year after that, they do keep the weight off. They do receive the improvement in their liver enzymes and liver tests and so on. What we don't have is what happens 10 years down the line. So as I say, there was only one study that I found where they have done, I think, around 25 patients involved, and they found that they followed them a 1 year, 2 year, and 10 years. At 2 years, the patients who had received balloon were doing better in terms of weight maintenance, in terms of their HbA1c, in terms of their liver enzymes, at 1 year and 2 year after the balloon therapy compared to control. But at 10 years, both the groups were similar. Okay, so at 10 years, there is a risk that patients will lose the advantage that they had with the balloon and have weight regain and the metabolic problems. However, what they found was that these patients who had successful balloon therapy were more acceptable to undergo surgery or more advanced procedures. The reason is because they had successful result with the balloon therapy, makes them more adaptable. That makes them more approachable, that this worked in the past, so it's likely that I have some other procedure for weight loss which is permanent, which has got better results in the long run. Then they do go ahead with surgical procedures eventually. So this is what I said, we could use it. So if patients meet the criteria for bariatric surgery, they are happy to undergo bariatric surgery. I think balloon is not there to replace bariatric surgery, but it's kind of a stepped procedure. Is we can offer this first if patients do not want bariatric surgery, or they do not meet the criteria. Uh, and then if they do meet the criteria, they can have bariatric surgery later on.
And just last one, would you recommend combined balloon and medical weight loss in higher BMI groups?
That's the $1,000,000 question, isn't it, Anaya? And you remember
Yes, it is.
we met up last year and we had this debate. So I think yes, why not? But the problem is, my only thing is, balloon is, as I said, very clear thing is balloon when we use, we have to ingrain to the patient that they have to make changes in their diet and lifestyle. And I think that is just part of the balloon therapy. The problem we have with the GLP-1, agonists and what are the new drugs we have, they take away the appetite completely. And the way that they are sold as of now, at least in the UK, is that patients don't change anything. They are advised, oh, that's fine, you just eat what you like, but you'll not have that appetite. And so we are combining apple and oranges here. That's my worry. So I would keep them separate. If they're having balloon therapy for 12 months or so, just focus on balloon therapy alone. Okay. And get them working with that. If they're going down the medical route, then they follow the medical route alone. That's what my advice is to patients. Do not combine the two.
Right. So I have a question, Dr. Brij.
Please.
So you mentioned that there's an incidence of 2 to 5% for the patients who are labeled as intolerant, and the balloon
Yes.
then comes out.
Yeah.
So my question is, when do you define that now this patient is intolerant? What
Hmm.
all have you tried before you are finally deciding that okay, now the balloon has to come out as a last option?
Yeah. So I think it varies from patient to patient. So as I said, most of the patients will have some degree of nausea, vomiting, acid reflux
Yeah.
in the first 48, 72 hours, and that generally settles. Now, some patients that takes up to a week. Okay. So if the patient has it for a week, I would encourage them to just stay on liquids only, maybe trial some different antiemetics for them and see how they go. Occasionally, if it doesn't work, I bring the patients in for intravenous antiemetics and intravenous fluid therapy and trial that for 24, 48 hours. And it depends upon what symptoms are they getting. If they're getting the cramps are worse, then as I said, I may give them some buscopan antispasmodic added on. Okay. So I'll trial everything before I would say that no, it's not working for you. So typically I would say around 2 weeks, I'll keep on trialing
2
different
weeks.
things. Okay. If the patient has not managed to have much in terms of oral fluid intake, even say at 2 weeks, then the worry is that they are at risk of having further problems like dehydration and kidney injury and whatnot. And then I think it's safer to remove the balloon. Obviously,
Right.
we have to be more careful with the diabetic patients because we don't want them develop hypoglycemia or other ketoacidosis and whatnot. So patient to patient, but in spite of all these efforts to keep the balloon, 2 weeks is generally my cutoff period. If they're still struggling, then I would remove it. Okay.
Right. Thank
And
you.
the other thing to add is occasionally I have seen late intolerance. So patients have had the balloon nicely, 5, 6, 7 months, there's no problem. And then suddenly in month seventh or eighth, they start having severe acid reflux symptoms. They get this, what the patients describe as sulfur burp. So their burp is like in really awful. And if that happens and they are starting with vomiting again, this could be hyperinflation, this could be secondary intolerance. But then again, by that time, thankfully, most of the patients have lost the weight, they've made the diet changes. So at that time,
Yes.
low threshold remove the balloon.
Yeah. It's in anyways, it's almost around time to remove the balloon, around that
Yes,
7, 8
yeah,
months on that.
exactly.
Right. So we are almost out of time. In fact, we have already overshot our session
Oh,
by
I'm
15
sorry.
minutes.
Yeah.
No, no, no worries. There's a very interesting discussion going on here. And I believe there are still some questions in the chat box from our audience. So, Parth, if you'd like to take them one by one quickly.
The first question is, what are the long-term results after removal of the balloon, Mr. Madhok? After
So
5
I
to
think
10
we
years.
have covered that, isn't it? There are not many long-term
Yeah.
results. There is only one study that I found, probably another one, showing in the long term, patients can regain the weight, but that is after 2 years. But till 2 years, there is good data to say most of them keep the weight off.
And how many of them have intractable dysphagia and the need for intervention to remove the balloon?
In dysphagia, I've not seen it. As I said, patient selection is the criteria. So if they don't have major dysphagia before the procedure, dysphagia is not usually a problem after the procedure. Balloon intolerance and requiring early removal, which we have just discussed with Dr. Bhalla.
Yeah. And two more questions we'll take.
Yeah.
Can balloon be removed at emergency and how to remove it?
Oh yes, sorry, I didn't cover that, did I? So there is a yes, it can be removed as an emergency. So it depends what the emergency is. Now, if the patient is vomiting exceptionally, high volume, and you are worried about gastric outlet obstruction, then I would say it is safer to remove the balloon under general anesthesia because you will have cover for their airway. So minimizes risk of aspiration. Okay. But if the patient is just having some vomiting and acid reflux, then you can remove it just as I showed the procedure to insert the balloon under mild sedation. You don't need general anesthesia. Okay. In terms of removal, same thing, do an endoscopy, and there is two special equipments provided by these companies, and you can find them anywhere. There is something called as a deflation needle. Okay, so that needle is attached to a catheter, so you can pass it down the endoscopic channel in the endoscope. Okay, sorry, biopsy channel in the endoscope. Put it down that, puncture the balloon with the needle, and the stillet that's there within the needle comes out, and attach the end of the catheter to a suction device, and you can just suck out all the 550 mils or whatever that you have used to inflate it. The balloon then completely collapses. And once you take that deflation needle out, and through the same biopsy channel, you can put a grasper. It's a two teeth grasper, quite a clear device. And I'm happy to share a couple of pictures for anybody about that. Not now, but I can email it to Bhavneet or to you, Parth. But there's a grasper specially device. You hold the balloon with the grasper, take a good bite, and you remove the balloon along with the endoscope under vision. Okay. So keep the balloon completely in view in the endoscope and gradually just keep pulling it out, and it comes out absolutely fine.
Okay.
The clear thing here is that you have to make sure the balloon is completely deflated. Okay. So pay extra attention to make sure balloon is deflated, because otherwise, while pulling, it can get stuck in the at the GOJ or at the cricopharyngeus. Okay. So once it's completely deflated, it should be fine.
Okay. So during our Q&A session, 3 more questions have been added.
No worries, yeah.
What to do for patients who haven't achieved more than 5% weight loss after 6 months? When do you convert to surgery?
So I think that's patient to patient basis, isn't it? So
Yeah.
I would say with the 12-month therapy, I sometimes do find that the patient hits a second peak at 7/8 a month as well. So if we have used the balloon that is designed for leaving for 12 months, I would say leave it for 12 months and offer a bit more support to the patient in terms of dietary changes, and see if there's anything they can do to make the balloon work. Okay. But if it doesn't work, you can proceed to surgery anytime. There is no contraindication. Once the balloon is out, after 2 weeks, you're safe to operate. You're safe to transact that stomach. It's completely reversible. There are no changes to the stomach wall or mucosa.
And do we have any balloons which are designed to be kept for more than 1 year?
No, I don't think so. I think 1 year is the maximum.
Yeah.
However, during COVID times where we had patients who were scheduled for removal and we could not do it, as we were restricted, the balloons have been left for 13, 14 months, and we have had no problem. So I would say if it gets delayed by a month here or there, should not cause major problems. Okay, but it's not, the companies will not advise it, they will not cover us if it's left for more than a year.
Okay. And is Allurion licensed in any other countries apart from UK, like in India or other countries?
Allurion is available in India, yes.
Yes.
It is certainly is available. I know quite a few friends doing it. Allurion is available in around 50 different countries. Today, you have started doing it recently, haven't you? Yeah. So Allurion is available internationally. Certainly in India, it's available. And I can find it out for you. If anybody's interested, I've put my contact details on the email. I can put you in
Yeah.
connection with the Allurion team. No problem.
Yeah. Dr. Sebastian
Good,
had asked that question. I will request him to directly get in touch with you. So one
Yes,
more
no
last
problem.
question, and then we'll have the closing remarks by the panelists. If the patient doesn't tolerate short anesthesia, then do you convert to J in the same sitting, or you would ask the patient to come again?
I can't, because you saw my setting, so I don't have a anesthetist with me. So it's just me. So I don't. But if the patient does not tolerate it, I bring them back another time.
Okay. Cool. So now I would like to invite Dr. Pintar and Dr. Siddesh to have some closing remarks, and then we will end the session.
Thank you so much, Parth.
So, a very important session, a lot of new informations for all of us, I suppose, and optimal discussion. And of course, many complicated patients are coming to our outpatient or inpatient clinics, and we need to approach anyone probably very personally, because there are many underlying factors that influence the final weight loss in these patients. Could you agree with me?
Absolutely, yes.
And
Can't agree more
what
today.
about we just probably need to all mention the impact of dieting in this group of patients, and in relation to different regions where we are coming from, and in relation also to the Mediterranean diet that is the highly impactful in all weight loss programs.
Yeah.
Do you comment on this?
No, so it's difficult to change somebody's dietary behavior completely, isn't it? But what I do tell them is it's all about how they eat. And that is important, okay? And obviously what they eat matters a lot more as well. But often it's how they eat. I advise them to focus on protein. So they should have a good source of protein in their diet. And as I said, one thing I say is, I don't know whether you've heard this before, is 20-20-20 rule. That's, I tell them for all the patients. So 20-20-20 is have small bites. So typically it's a 20p size coin, which is probably similar to a smaller than a 50p, 50 paisa size coin in India, I guess, or the new 1 rupee coin, but very small bites. Okay. Chew that 20 times before they swallow it, and at least eat for 20 minutes. Because a lot of us, busy family lives and whatnot, eat too quickly, and before you realize you were overeaten. So give that time for the stomach to send signal to your brain that it is full. And that's a very subtle thing that patients do need to realize. And this is, I go through in detail with them more rather than me. My dietitians go through quite a detailed assessment for these things. I think that is more important today, because we can't change the diet completely for patients, I think. But so long as they focus on healthy eating habits, I tell them, don't take these McDonald's, sugary drinks that will just go down easily around the balloon. You will not have the satisfaction, you'll not have the sensation of fullness with it, and you've
Yeah.
had loads of empty calories.
Yeah, that's true.
This is a part
Yes.
of success.
Yeah.
I don't know, but I do tell them. And one thing I do tell them is to avoid fizzy drink generally, because that can make the bloating worse with the balloon, the distension and the cramp. So these are the few things I tell them.
The importance of diet cannot be overemphasized. One last closing remark from
Yeah.
Dr. Siddesh.
Yeah, thank you, Parth. That has been a wonderful evening for me in India, but listening to this very nice talk, and also very good interactive session, bringing out a lot of points. My just last feeling, what I would like to convey to the audience is balloon is not a magic. It's not a final or the very good or the only option for treating obesity. There are many procedures, but balloon is also one of them.
Yeah.
Though it appears easy, it is not as easy as it appears. And he has got a lot of caveats attached to it. We need to realize them. Most important caveat would be the psychosocial counseling, which is very integral part, which has been often discussed, and also now the expert comments and the discussion has been all about that. We need to have a proper counseling and patient selection. And of course, being in India, our patient diaspora, we need to keep their points, what is special about them. So we need to be very choosy and give them a very appropriate procedure, because the patient's knowledge about whatever you talk to them, they may not be able to finally understand and get the best out of it. The best procedure is one where a surgeon understands the patient very well, understands the psychosomatic behavior and also their social and economical status, and then take a call, contribute to their decision, as well as hear them well, so well to take the final call. I think, thank you very much again for this, asking me to be part of this program, Dr. Bala Parth.
Yeah.
And that has been a wonderful evening, Dr. Madhok, for your talk. And nice
Thank you so
comments
much, sir.
by
Thank
Dr.
you.
Pinter. Thank you.
Yeah,
Thank you, sir.
Dr.
Thank you, sir.
Dr.
Wonderfully
Bala
summed up
for
everything.
Yeah.
Yeah. So I think it's time to wrap up now. So thank you all, our guest speakers, Dr. Madhok, our chairpersons, Dr. Siddesh, Dr. Taija, for this wonderful and a very interactive session. I'm sure everybody has thoroughly learned something from this and thoroughly enjoyed this discussion, with a lot of questions coming in from all our attendees. So we thank you all for joining us today on this Sunday. It's evening here. It's almost evening now, and hope to looking forward to meeting you all sometime soon in person. And
Definitely.
do join us in our next coming academic activities also. So thank you once again, and have a
Thank you.
great day.
Thank you.
Have a great day.
Thank you.